Hello, sir. Sorry for the inconvenience, sir. We are having some technical issues. Could we have the clarification session again, sir?
Okay, fine.
Sir, thank you,
Thank
sir.
you. Thank you.
Thank you so much, sir. It was very precise and relevant presentation. I'm sure all of us can relate each and every word that you mentioned. Thank you so much, sir.
Thank you. Thank you, madam. Please go ahead.
Yes, sir. Thank you, sir. Now I'd like to welcome our next guest speaker. We are extremely honored to welcome Ms. Palarmati Arunachalam, Senior Lecturer and Doctoral Scholar, Sri Ramachandra Institute of Higher Education and Research, Porur, Chennai. Ma'am has completed her BSc Optometry in 2000 in Elite School of Optometry, Birla Institute of Technology and Science, Pilani, Rajasthan, and MPhil in Optometry on 2007, Elite School of Optometry, Birla Institute of Technology and Science, Pilani, Rajasthan. And ma'am is pursuing PhD at Sri Ramachandra University in Chennai. And ma'am is also pursuing FCOD in College of Optometrist in Vision Development, USA. And ma'am also got license to practice orthokeratology by Paragon Vision Sciences by USA. And she is a proficient optometrist with 19 years of experience. And she also has been actively performing clinical research and has authorized book chapters, presented and published research papers also. And ma'am has the teaching experiences like she worked as an instructor in Elite School of Optometry from 2002 to 2010 and as a visiting lecturer in Elite School of Optometry from 2002 to 2012 and as a visiting lecturer in Arubadi Vidu Medical College from 2011 to 2012 and as a lecturer in Sri Jayendra Saraswati Institute of Medical Science from 2011 to May 2012 and as worked as a lecturer at Sri Ramachandra University from June 2012 to September 2016 and as a senior lecturer in Sri Ramachandra University from September 2016 to till date. And ma'am has the clinical experiences which includes primary care optometric services and specialty services including binocular vision, contact lens practice and low vision care and rehabilitation at the world-renowned multi-specialty hospital. And ma'am also has the experience in diagnosing wide variety of ocular disorders and also expertise in fitting contact lenses for infants and toddlers as a part of early intervention services for the pediatric population and rehabilitating the visually challenged children. And ma'am has got the honors and awards like Best Paper Award from All India Optometry Conference held between 30th March to 1 April 2018 at the Constitution Club of India, New Delhi in India. And IVA Higher Education Scholarship for pursuing PhD and Sri R. Sivaraman Memorial Endowment Prize for the best performance in research project during August 2005 to July 2007. And letter of appreciation in doing excellent refraction, especially for children in November 2011. And ma'am also got the certification of appreciation for punctuality and devotion in clinical service during internship in March 2000. And ma'am also got the certificate of appreciation for creativity on the occasion of World Optometry Day on March in 1999. And she is also a member of various optometric association. Currently, ma'am is working as a lecturer, senior lecturer at Sri Ramachandra University, Porur, Chennai, and consultant optometrist in iTech Optometric Care, Chennai. Welcome you, ma'am.
Thank you, madam, for that elaborate introduction. I don't think anybody has given such an introduction to me before. Thank you so much.
Thank you.
And on this warm Monday, my respects to Dr. Sudha madam, principal and all the organizers and participants. For the next half an hour, we are going to explore about refractive errors of the eye. Can I share my screen?
Ma'am,
Is it possible?
is it visible, ma'am?
It's visible, but how do I change to the next slides?
Ma'am, I will do it for you, ma'am.
That would be difficult.
Then I have to make you as a host, ma'am.
Mm.
Is it okay for you?
Can you make me as co-host?
No,
Madam,
ma'am.
you just need
Option
to
is not
allow her
available.
to share the slides. You need not.
That's all.
Yeah,
Just
you need
click
not
share
make her
screen.
host. Yeah, you just allow her to share the screen. There will be an option to allow.
Ma'am, now you can try it, ma'am. I have changed the settings.
Okay, is my screen visible?
Yes, ma'am.
Yeah. Thank you. For the next half an hour, we are going to explore about refractive errors of the eye. If you think of a question in between, please jot it down. We can answer them at the end just to keep up the momentum of the session. So my topic is on refractive errors in children. So the objective of this session would be, we will try and find out how vision is formed, how we experience vision, and then the types of refractive errors and how we are going to correct them. So most of you would have come across situations where the parents might have complained that my child is keeping books so close to the eyes or just lying down on the book while reading, or it can be saying that their child Janu cannot see anything from the uh, board. Teachers complaining that Janu comes closer to the blackboard in the classroom. Or you could have noticed your cousins or your friends' children going very close to the television when they are watching their cartoons, isn't so? So why does these happen? When we don't go much closer to the books, we hold a normal working distance. We put it at the hand's distance to read. We don't go close to the blackboard. We don't watch TV from closer distance. Why do these children do? This is because there are some eye defects. There are some underlying defects in the eye. Let's understand what these eye defects are. But then, before going into the eye defects per se, we should know what is normal, isn't it? Only then I can say this is defective. If I don't know what is normal, then I would not be able to find the defect. Okay, so a little bit of it we will try and understand the eye and see what is normal, and then we will jump into the defects in the eye. So we can compare the visual system to a camera. Like you have an aperture in the camera, we also have an aperture that allows the light to enter the eye. Okay, like the card or the film captures the images, likewise retina also captures the images. Okay, so whatever light that passes through the eye, it passes basically through this system. This system is called the, this is the cornea of the eye. Then you have this lens. Okay, both these focuses the eye rays on the specific point at the back of the eye. This is called the macular region, and this is, the whole thing is the retinal zone. Okay, so things get focused on the retinal zone at a very specific point called the macula, and these two structures, namely the cornea and the lens, helps us to focus the images on the macula. Okay, so how this image is formed? So if you have a light source, light passes through the cornea lens, and focuses on the macula like this. Can you see what is different in this? I have given an erect candle, but the image that is formed on the retina is inverted. Can you notice that the image formed on this retina? So look at this here. When you see the image, I have some technical issues, I believe. So here you can see this is an inverted image. If this is the end of the visual system, then probably we will see the world to be inverted upside down. So what happens? Okay. So whatever the image is formed on the retina goes to the brain. All the information that's formed on the retina is transmitted to the brain, and the brain reinverts the image. So the initial object and the image formed on the brain are normal. That is why we are able to see all things erect. This is the basic funda in how we are able to see things. Okay, so this is what is happening. So when you have an object, the object passes through the cornea, passes through the lens, and focuses exactly at the point on the retina. This is normal. So now what is abnormal? If this point, this central point on the retina is moved either forward or moved backward, then we call it there is a defect. Okay. So here, when you see in this first picture, you can see that the image is moved forward. Okay. So here the light rays are not focused exactly on the retina, but they are focused at a point in front of the retina. Similarly, in the other picture, the rays are not formed exactly on the retina, but they are formed at a point behind retina. So, these conditions we call it as refractive errors. Okay, rather than forming the image on the retina, they form the image either in front or behind the retina. Okay, so why does this error occur? Why should the image form either in front or behind? Okay, there are two basic factors why this happens. Okay, one is the curvature of the eye. So the curvature is either too steep like this, or the curvature is too flat like this. So when it is too steep, it converges more and forms the image much in front of the eye. If the curvature is flat, it has poor converging power, so it forms an image much further away from the actual position. Okay, apart from this, we also have the length of the eyeball contribute to this defect. Okay, so if the length of the eyeball is too small, or if it is too big like this, in both the conditions, the image is not formed exactly on the retina, but they are formed either in front or behind. So based on how the image is formed, we classify the refractive errors in children basically as myopia, hyperopia, and astigmatism. In children, these three are quite common. Okay, so let's go into each of it in detail. Coming to myopia, myopia in your 12th class you should have read. It is also called as short-sightedness, which means you will be able to see objects that are very close by, whereas you will not be able to see objects that are further away, okay, at long distances, okay. So in such instances, myopia occur. So myopia occurs when light rays focus much in front of the retina because the eye is too long or this cornea portion is too steep, okay. In both the instances, the image is not focused on the retina, but it is focused in front of the retina itself. So what does these children complain of? Okay. So when the child is having myopia, usually the teacher or the student or the parent would identify that the child is not able to copy anything from the blackboard. The child is not or copies inaccurately because the child is not able to figure out what is written. The child often does not attempt to write because it is not able to see. Okay. So all this could be underlying fact that the child is experiencing myopia. Okay. Also, because the child is putting more efforts to figure out a blur on the distant target, the child might end up with eye strain or headache. Okay, these are also quite common. So in all these instances, when the child complains, it should be seriously taken and given notice of. Take them to an optometrist and have an eye examination just to rule out if the child is not suffering from myopia. Okay. So what should we do if we figure out myopia in a child? Okay. So here what happens, the image is formed very close to the eye retina, in front of the retina, which means the converging is greater. Okay. So we will diverge it little bit and allow it to focus exactly on the retina. So we use a diverging lens or a concave lens which diverges the rays little bit and then bring it to a focus on the retina. Okay, these are given in the form of spectacle lenses. Apart from this spectacle lenses, so if you correct the eye, then probably the board will become clear like this. Okay. So if it is blurred, the patient is going to experience a blurred blackboard. When you put the patient on this spectacles glasses, then you are going to experience a clear board vision or distance vision. So apart from correcting the with the help of glasses, we can also use contact lenses. The contact lenses are placed much closer to the eye, exactly on the cornea. It's a thin plastic lens. It's biocompatible and it is worn on a daily basis. Morning you wear it and evening before going to bed you remove it. Okay. This will help to focus the images on the retina. Okay. Apart from this, we can also control myopia by using any of these. Okay. We can use drops. We use a small amount of atropine eye drops to control the progression of myopia. We use multifocal lenses so that the eyes do not get strained and elongate over a period of time. We also have some corneal reshaping like orthokeratology. We put the contact lenses overnight and ask the patient to sleep with the contact lenses. If the patient sleeps with the contact lenses, there is some amount of flattening of the cornea that happens. Okay. So in the morning, once you remove the contact lenses, this flattening can help them to focus the images on the retina. Okay. Apart from this, the best way of controlling myopia is to have a lifestyle modification. Okay. So what is this lifestyle modification? Improve the access of children to natural light. Allow them to stay outdoors for more period of time. Let them walk, play, cycle, go with the dog. Whatever they want to do, let them do it outside. Okay. Apart from this, if you could delay the giving or introducing the screens, be it television screens, laptops, tablets, mobile phones, you please do not expose children to any of these digital gadgets. Strictly before 2 years of age, absolutely no screen time, zero screen time. Do not put the child before the television and you go and do your work. Okay, that's a wrong way. Digital digital devices will harm the eyes and it will lead to many eye strain and improper development of the eyes. Okay, digital screens are not to be used as babysitters. When the child is before the TV, my child is silent, so I would make use of it. No, digital screens are not going to act as babysitters. Okay, so before 2 years of age, the child should not be exposed to any of the digital gadgets. Even after 2 years of age, it's only restricted to half an hour or 1 hour or 2 hours, depending on the age of the child. Apart from this, the children should be taken for a walk. They should be allowed to go to the park and play. They can be allowed to go for cycling, swimming, any of the outdoor activities. Okay, skating. All this will improve their health and keep their eyes healthy and keep away myopia. Next, coming to hyperopia. In myopia, the images formed in front of the eyes, whereas in hyperopia, the image is going to be formed behind the retina. Why behind the retina? Is because the eye is too small or the front corneal curvature that is here is too flat. The curvature here is too flat or the overall length of the eyeball is so small. That's why the image is formed behind the retina. So look here. I think in the screen it is moved. Okay. So how are we going to manage hyperopia? Some hyperopia at birth is common. All are born a little bit of hyperopic. Say until 3 diopters of power at birth is acceptable. Okay. So as we grow older and older and older, the eyeball is going to increase in size. So by 2 years of age or by 5 years of age, the entire hyperopia will go off. Okay. So having 3 diopters of hyperopia at birth is normal. Apart from that, if we have more than 3 diopters of hyperopia at birth, then the child is going to have complaints of drowsiness, headache, difficulty in holding the near target for long. Okay, all this can happen. Okay. So how do we correct hyperopia? We use what is called as convex lenses. Okay, so here we have put a convex lens. When we put a convex lens, whatever image that has formed behind the retina will come to a focus now on the retina, because this convex lens will improve the converging power of the rays of light. So instead of traveling far behind the eyes, it will be focused in front on the retina itself. So to correct hyperopia, we can also use contact lenses. In both myopia or hyperopia or any refractive errors, surgical options are not advised in the pediatric population. If at all you have to think of surgeries to correct myopia or hyperopia, it's only after 20 years of age when the power has stabilized. Okay, So as long as the body is going to grow, the eye is also going to grow. Okay, so the power is going to keep on changing, be it hyperopia or myopia. Myopia, it is going to increase, hyperopia, it is going to decrease. Okay, so after 20 years, when the body has stopped increasing in size, in stopped growing, so you go horizontally, that is different. Okay, so overall, if your growth of the other structures has decreased, then you start thinking of any surgical intervention. Till then, we are not going to do any surgical interventions for hyperopia or myopia. So a quick recap. Okay, so we have seen about myopia and hyperopia, and the rays are formed in front in myopia and behind in hyperopia. But what is more important to be noted here is that we are getting a point focus. Okay, so you can see that it is a point focus. All the rays converge to one particular point on the eye, either in front or behind. Okay, so in the next case, this does not happen. Okay, so that condition is called as astigmatism. In astigmatism, because of the shape of the cornea or the lens inside the eye, the rays that focus on the retina all do not come to one point focus. Okay, so one set of rays comes to a focus at one point, and another set of rays comes to a focus like another point. Okay, see, is the shape of the eye is like more similar to a football than a baseball. Okay, so here when you have a football, you have same curvature, you have different curvatures like flatter curvature and steeper curvature, rather than having a spherical cornea, spherical eye. Okay, so in the previous things, we saw that all the rays comes to focus, whether it is through the horizontal rays or vertical rays that are passing through the eye, all come to one focal point as in the above picture. Whereas in case of astigmatism, the horizontal rays come to a focus at one point and the vertical rays comes to a focus at another point. So you have multiple focal points in case of astigmatism. So if a patient is having astigmatism, his experience when he looks at a light, okay, will be like elongated to one direction. This elongation can be horizontal or can be vertical, but instead of seeing the light as one small unit, you see the light to be an extended ray. Okay, like in the picture on your left. So how do we correct this astigmatism? In myopia, we used concave lenses or diverging lenses. In hyperopia, we used convex lenses or converging lenses. But in astigmatism, we are going to use a special type of lens called cylindrical lenses. Okay, this can be with a combination of spherical lenses also, in which case we call it as spherocylindrical lenses. But basically, to correct astigmatism, we make use of the cylindrical lenses. Okay, so in summary about the refractive errors of the eye, we have myopia corrected with concave lenses, hyperopia corrected with convex lenses, and astigmatism corrected with cylindrical lenses. So there is one special condition that we will come across in children, that is called as aphakia. Aphakia represents an absence of crystalline lens in the eye. Okay, in the previous picture, you could have seen this lens inside the eye. Behind the cornea, you have this lens, no, this small blue color curved one in each of the pictures. This lens will be absent. This lens will be absent. Why? Because it would have become opacified like here. Like here, this lens would have become opacified because it does not allow to light to pass through and focus on the retina. We have to remove this obstacle. Okay, so in due course what we will do, we will surgically remove this crystalline lens from the eye. So, as Sandeep sir has said, crystalline lens contributes to around 70 diopters of power for the total 60 diopters power, isn't it? So, if you remove this 17 diopters of power from the eye, then the image or the light rays are not going to focus on the retina. They are the converging power or the focusing power of the eye becomes reduced, so it will focus at a point much further away from the retina or behind the retina. So what we generally do in children is we need to correct them with glasses. See here, there is no lens here. Okay. So when there is a lens, the image will be focused on the retina. Because there is no lens, the image is focused behind the retina. So this lens, we bring it forward. That convex lens, we bring it forward and prescribe it in the form of glasses. Okay. So when we prescribe it in the form of glasses, the image will be allowed to fall exactly on the retinal zone. So how do we prescribe? Such thick glasses you would have seen. If the patient is wearing such thick glasses, then it means that the child is aphakic. Okay. This can be high hypermetropia also sometimes, but most of the times it is aphakic. Okay. But if we do not put these glasses on the patient, then probably the patient might be left blind or can suffer from what we call it as amblyopia. Okay, like you heard in the previous session, amblyopia is like lazy eye. The eye will not recognize the light that is focused on it. Okay. So let's get into some quick facts. Why should we learn about refractive errors? Why we should have awareness about refractive errors is because uncorrected refractive error is the second major cause of blindness and low vision in the world. It's not only in India, globally, uncorrected refractive error is a major cause of blindness. Okay. In fact, this is a preventable blindness. If you find refractive errors, if you identify refractive errors earlier, you prescribe glasses, allow the patient to wear the glasses regularly, then we can prevent blindness. We can prevent blindness. Millions and millions of people are suffering from blindness just because their refractive error has not been identified at the right time. Okay, childhood is the best time to uh, identify refractive errors, but children cannot communicate. Children cannot communicate that they are not able to see. Okay, they think that everyone sees only at that distance. Everyone is seeing only to the level that they are seeing, so they will not be able to communicate. The largest burden of refractive error is in India and China. Most intellectual peoples, isn't it? So intellectual peoples read more, do lot of near work, stay away from playing. That's why they carry a largest burden of refractive error. So how I am going to address this refractive error is like having a school health program, conducting regular eye camps we can identify the refractive error in the early childhood, give them glasses so that we can avoid blindness in children. I cannot do everything. There are millions and millions of people. How can we address this issue? There are lots of schools running in the country. How do I go school by school? You can recruit the teachers. Okay, in each of the school, you try to train the science teachers and teachers who are wearing glasses, so they know the need of the screening program. Okay, so once you train these teachers, so even when the child is getting admitted into the school, they should have a thorough eye examination to be eligible to take an admission. Okay, so health care should be part of the admission process. So school authorities also should support this one. Okay. So train the teachers to refer each one case by case basis. They should refer it. And if the child has been identified and glasses has been established, the child stays in the school for long hours. Okay. So the teacher should be taking the responsibility of ensuring that the child wears the glasses regularly in school. Okay, it's not only the parents who should be responsible. As a community, teachers also should be responsible for helping us in establishing good vision for our future citizens. So we should insist on wearing spectacle lenses, and this can also be given free of cost for the people who cannot afford it. Okay. So in conclusion, refractive error is the second largest cause of avoidable blindness. Correction, as we saw now, is relatively simple. Sir has told you about the examination process. Just 2 or 3 tests you do refract the eyes, and you can identify the refractive errors and prescribe them in the form of simple glasses. We needn't have to go for any complicated correction. Simple glasses can do wonders in this case. Okay. So comprehensive service delivery at school will be a pertinent point. As nursing students, you can also play a major role in in supporting this healthcare venture. I thank Dr. Sudha ma'am, Professor and Head of Pediatric Nursing, and the IQAC team of Vinayaga Mission and the entire organizers for giving me this opportunity. And I thank the participants for their active listening. Wishing you all a great week ahead, filled with smiles, happiness, and all of the good things in life. And I'd be happy to take any questions if you have.
I request the participants to put your queries on the chat box. Participants, if you are having any queries, please write it in the chat box. Thank you all. Thank you very much, ma'am. It was a very provoking and insightful presentation indeed. Your thoughts are going to stay with all of us. Next, I would like to invite Dr. Kirtana, MS Ophthalmology, Junior Resident, JIPMER, to share about infection of the eyes. Welcome you, ma'am. Ma'am has completed MBBS from JIPMER in 2018 and got distinction in pediatric, obstetric and gynecology and physiology. And currently, ma'am is pursuing MS Ophthalmology from JIPMER. Welcome you, ma'am.
Thank you for giving me this wonderful opportunity. Am I visible? Is my screen sharing?
No, ma'am.
1 second. Is my screen visible?
Yes, ma'am.
Yes. One second. I thank the entire team members and the organizers for giving me this wonderful opportunity to present in this forum. And the topic of my presentation for today's lecture is eye infections in children. So let's all think like what is the importance or what is the need that we should need, we should need to know about the pediatric eye infections. This is because if you see in a pediatric OPD or be it in an ophthalmic OPD, the second most common presentation that brings about a pediatric child to the OPD is mainly the acute red eye presentation. And it is more very much worrisome for the patients also, for the parents also. One second. For the parents also, though it is acute in onset and it is shorter course in its presentation, if it is left untreated or it is not treated accordingly, it would lead on to long-term comorbidities in the children. So what as a medical practitioner or as a nursing care, what we have to do is we have to timely manage the case, whichever is coming to our care. We have to timely manage it. We have to adequately pick up the superficial ocular infections in the children. Along with that, it is very, very important to counsel the parents regarding the eye care during the presentation of the infection, because taking necessary eye care or managing it conservatively would cause resolving of the infections more than the treatment per se. So before going into the classification of infection, let's look into the external anatomy of the eye so that we can get the overview of what infections are we going to look and manage accordingly. So I'm not going to discuss here the deeper infections of the eye, which is left to the ophthalmologist. Here mainly we are going to focus on the superficial ocular surface infections, which as a medical care professionals or as a nursing care professional, we can easily pick up and we can identify, we can manage conservatively before referring to an ophthalmologist. So if you see in this picture, referring to the infections of eye means I'm going to talk about both the ocular as well the periocular infections. So if you see the conjunctiva has two parts. One is the bulbar conjunctiva, other is the palpebral conjunctiva. Bulbar conjunctiva is the one which holds the globe, and the palpebral conjunctiva is one which is lining the back of the eyes. So, and if you see in the side, this is the lacrimal gland. So, this is the lacrimal gland, and onto the right side, there is lacrimal drainage system. Coming to the periocular structures, we are mainly concerned with the lids and the lashes. Can someone please?
Sorry for the interruption. I kindly request all the participants to mute their system. Lot of disturbance.
Shall I continue?
Thank you. Yeah.
So if we see in periocular structures, we are more concerned with the lids along with the lashes, and coming to the orbit in which the eyeball is placed. So we can commonly identify these infections and we can conservatively manage it. So let's go on to the classification of the infections. The structures that we are going to see are conjunctiva, cornea, lids, orbit, as I discussed earlier. So first thing is the conjunctivitis. Conjunctivitis is the most common presentation that would bring the parents' notice to refer to a pediatrician or to an ophthalmologist. So how does a child with conjunctivitis usually present to you with? So typically, they'll come to you with history of 2 to 3 days of acute red eye presentation. As you can see in the picture, the child is having bilateral red eye or pink eye, we would say in the clinical practice. So it is very much bothering to the parents. Since they may think it is a vision threatening condition, so we have to refer it urgently. Yes, it is an emergency condition, but it can be very well managed. We have to counsel the patient that with adequate eye care, we can avoid the infections. So conjunctivitis itself has so many types. They can be bacterial, they can be viral, they can be of allergic, or they can be of chemical conjunctivitis. The lucky thing is that we can actually easily differentiate based on the presenting complaints of the child. So if we carefully look into the history, we can easily differentiate between the 4 types. So first is the bacterial conjunctivitis. If you take the other types of conjunctivitis, about 83% of the cause is attributed by the bacterial conjunctivitis. So what is the history that they will typically present you with? So typically they will present you with acute red eye, especially it will be like for 2 to 3 days history. So 2 to 3 days of acute red eye associated with excessive watering. Then the main clenching point that it pertains to bacterial conjunctivitis is the mucopurulent discharge, which is not present in other type of the conjunctivitis. Be it viral, allergic, or in the chemical conjunctivitis, there is not going to be the mucopurulent discharge. Along with that, there is one more common history, which is common in all other conjunctivitis also. There is going to be history of sticky eye. The mother will complain that the baby is not able to open the eyes in the morning. So that would be a specific complaint. And the bacterial conjunctivitis can be unilateral or they can be bilateral. Unilateral, why? Because secondary to presence of foreign body, if it is not noted in appropriate time, it can secondarily infect and result in the bacterial conjunctivitis. Or there can be a systemic association. There can be a systemic infection which could have led on to bilateral conjunctivitis. As a systemic presentation, it is presenting as conjunctivitis. So those are the causes. So what do you do if a patient comes to you with a red eye and you're suspecting a bacterial conjunctivitis? Always you have to retract the lower lid of the patient and you have to look the cul-de-sac. This is the cavity or the cul-de-sac where the secretions of the eye would get collected. Why it is getting collected only in the lower sac? This is because of the effect of gravity. The secretions of the eye is going to collect in the sac. And also, what do we look in the lids? Since I told you earlier in the slide that the conjunctiva is going to line the globe, as well it is going to line the lower part of the lids. So we have to inspect for the congestion. Any kind of conjunctivitis not only present as diffuse conjunctival congestion in the globe surface, it also has congestion in the over the lid margins and the lid surface also. Palpebral conjunctiva also would show the congestion. So we look for the congestion and we look for the discharge. Then what do we do? In case if you are suspecting a bacterial conjunctivitis, we would go for the investigation. We would not wait for the management of an ophthalmologist. We can ourselves take a sterile cotton swab or a bud. We can take the discharge that's been already collected in the cul-de-sac, and then we can take a bud. We have to rotate it from inner fornix to outer fornix, not in the opposite way, and we can collect the discharge. So that discharge, they can be sent to 3 tests. One is the gram stain and culture. Gram stain and culture comes in hand. Then genes are stain. What do we do? What do we need? What do we do in gram stain? Gram stain and culture both are same. They are going to detect the group of bacteria, which is the causative agent for the conjunctivitis. Gram stain is going to give an overall view what group of organism it is, whereas the culture is going to specifically say which organism has caused it. Whereas what is the use of gene sustain that we are doing? Gene sustain is going to tell which cells are predominant. In bacterial conjunctivitis, there is going to be predominance of the neutrophils, whereas in the viral conjunctivitis, there is going to be more of a lymphocytes, and in the allergic, it's going to be more of eosinophils. So based on that, we can make our diagnosis. Next thing is the cleaning of mucopurulent discharge. I will talk about later how do we clean the eyes and how do we give warm compresses and how do we prepare a lid scrub and all. And then we can refer to an ophthalmologist. If there is a slit lamp in your OPD, you can even look in the presence of follicles in the papilla. I have added the difference of follicles and papilla. It is, you can basically identify, you can have a broad overview. I'm not going in detail like how to differentiate and all. Just I'm giving a minor difference. Like if you see, follicles are a vascular mound of growth. In the right side of the slide, if you see, follicles are the vascular mound of growth, whereas papilla are the vascular mound of growth, whereas follicles are tiny water-filled vesicle kind of thing, which is clustered in the lid margins. So where the follicles are found, the follicles are mainly found in the viral conjunctivitis and in the allergic conjunctivitis, whereas papilla will be found in the bacterial conjunctivitis. This is of more advance, but we can actually, after cleaning and after sending it to culture and sensitivity, we can refer to an ophthalmologist. They will appropriately treat with 4th generation fluoroquinolones topical antibiotics along with the lubricants. So coming to the viral conjunctivitis. Viral conjunctivitis also will have a similar presentation. That is, there is going to be acute red eye lasting for some 2 to 3 days. Associated with, there is going to be excessive tearing of the child, and then there is going to be a sticky eye. This is the commonest presentation for all conjunctivitis. But the clinching point in diagnosis is that you have to see what is the presentation. It's going to be always bilateral because it is secondary to the upper respiratory tract infections. It is a concurrent presentation of the upper respiratory tract infection. So the child will have upper respiratory tract infection. Sometimes he can have high grade fever. He or she can have a high grade fever. And if you well clinch the history, there can also be a family history. There can also be a family history because the viral conjunctivitis is very highly contagious, and you have to mainly instruct the parents that they have to avoid the fomites. What does fomites means? Fomites means whatever comes in contact with the infected eye secretions are pertaining to the fomites here. So like face towels or handkerchiefs or whichever that comes in contact with the eyes, bed pillows, bed sheets, whatever the child is in contact with have to be properly washed, and it should be separated from rest of the family members because it has a high rate of spread. Also, other signs like which will say that it is a viral conjunctivitis is that if you carefully examine the patient, like they'll be having URI, fever. Along with that, if you carefully examine and physical examination only, there is going to be enlargement of the post-auricular nodes. Along with that, since I told you it's a bilateral presentation, along with the conjunctiva, there can also be a corneal presentation also. So if we have a cotton in our OPD or some cottons, we can check for the corneal sensation if it's present or not, and then we can proceed with staining. So this can be left to an ophthalmologist, or if you're interested or more want to see under slit lamp and all, you can always, there can be a presence of superficial punctate keratopathies, which are dot like structures in the cornea, over the cornea, which can be seen with the stain. What I'm saying is there is always an association of the cornea involvement along with this conjunctiva in viral conjunctivitis. Okay. Then how do we diagnose and manage? So basically here it is a self-limiting condition. So what do we instruct the patient's attenders is that main thing is that to avoid fomites, that it has to be separated and washed, and there should not be any close contact with the infected patient, and we have to advise them cold compresses. Along with that, in order to reduce the inflammation and the redness, we are providing them topical non-steroidal anti-inflammatory agents. Also, you have to inspect the eyelids in case of a viral conjunctivitis, because some other lid infections, which I will discuss in later slide, can also cause involvement of conjunctiva and cornea, and it can present similar to the viral conjunctivitis. So we have to always inspect the lids also. Lid infections also can present as a red eye. Next is the allergic conjunctivitis. In allergic and viral conjunctivitis, both will be having a similar presentation. The allergic conjunctivitis patient also will be having some nasal discharge and all, but the clinching point in the diagnosis is that they will be having a predominant itch sensation. The patient or the child will complain predominant itch sensation associated with excessive tearing. Also, this is going to be bilateral because this is a systemic condition secondary to allergy. And if you inspect and see, they will also complain of foreign body sensation. So whenever they complain of foreign body sensation and itch, it is allergic conjunctivitis. But foreign body sensation symptoms should not be left as such. Always, if a patient complains of foreign body sensation, we should either inform an ophthalmologist or ourselves. We have to, in case of we have a slit lamp, we have to look for the foreign body. We have to rule out the foreign body. Then only we have to confirm it as an allergic conjunctivitis entity. Next thing is that they will have a previous history, or they will be usually an allergic individual with history of atopy, or they will have eczema, or they may be an asthmatic on medications. And if you typically see, the allergic conjunctivitis will be more commoner in some season, like where the pollen grain loads are more. That is the season where the allergic conjunctivitis would tend to manifest. Okay. In examination, there is going to be some huge follicles on the undersurface of the lids. So this is how it will be. This is a classical feature. This could be of any grade, can be mild, moderate, or it can be severe type also. So because of the mechanical effect of the follicles, giant follicles over the cornea, it's going to erode on the cornea, and it can result in a defect. Some superior corneal defect it can result in, and that is called shield ulcer. There can also be involvement of limbus. This is the limbus of the cornea. There can be also involvement of the corneal limbus. Some follicles can be there. So these are the presentations. How do we treat them? We treat them by, we can send to them with the systemic oral antihistaminics to ophthalmologists. They can treat them topically. These findings are seen only under the slit lamp. We can't see it through the naked eye. We can prescribe topical and oral antihistaminics. Okay. Chemical conjunctivitis. Here our role comes. This is very, very important, an emergency situation that we will all panic, like how to manage, like what if the ophthalmologist is not near? What do we do with this condition? We should not panic. Okay. It's a life-threatening condition only. It is a vision-threatening, life-threatening condition. But what from our side we can do is, we have to, as soon as the patient comes, without doing anything, without any history or anything, if there is a history of chemical conjunctivitis or chemical injury you are suspecting to the eye, there should be prompt starting of the ringer lactate infusion. It should be done like the bottles of ringer lactate infusion is calculated based upon the pH. You have to measure with the pH paper. You have to start the ringer lactate infusion, and after some time you have to measure. After 2 to 3 bottles, you have to measure the pH. The pH should come to neutral, be it the chemical attack by an acid or be it by an alkali. It should come to the neutral pH. So that's when you can realize that the ocular surface is free of acid or alkali. Okay, so, and you have to remember that the history of alkali or acid injury, the alkali will be more injurious to the eye. It will be more penetrating to the ocular structure, more vision threatening. So after giving ringer lactate, we can refer to an ophthalmologist. I'll just briefly I'll just briefly tell like what we will be doing. Since there will be superficial erosions of the conjunctiva and the cornea, there should be there will be impairment in the wound healing, and there will be impairment in the tearing also. There will be associated dry eye. So we will provide them with lubricants. Since there is erosion of the superficial corneal and conjunctival surfaces, we will provide them with topical antibiotics. Along with that, there is going to be poor wound healing because the superficial layer is breached. So we have to provide them vitamin C supplements, and the inflammation will be more. So we will provide them with topical steroids. So this will be the overall management in short for the chemical conjunctivitis. And one more common chemical conjunctivitis that present to us is going to be a chlorine water. This is the most common. There will be history of swimming pool, like visit to swimming pool. So whichever part that's exposed, whichever conjunctiva that's exposed to the chlorinated water or the cornea, that will be congested. And the rest of the cornea and the conjunctiva would be normal. So that would be one of the other chemical conjunctivitis, which is more common. So in such cases also we have to give RL wash. Next is the ophthalmia neonatorum. This is also one kind of conjunctivitis. This is mainly caused in a much younger age, that is in the neonates. So during birth it is not going to present, but after 1 to 2 weeks of the birth, it is going to the neonate is going to present with bilateral profuse mucopurulent discharge. It is going to be so profuse that we haven't seen such a condition in our life. So it's going to be very profuse. It is mainly because if the mother's sexually transmitted infection is not treated adequately, that too she is giving a vaginal delivery. So in such cases, the child could acquire the ocular infection during its passage in the maternal genitalia. So how can we avoid? Simply we can avoid. We can screen the mother for if she's having some fever, or we can simply screen her for the torch infections, and we can start her on a prophylactic antibiotics. Be it she has a fever or not, we have to start her on a prophylactic antibiotics. So if we do so, we can easily avoid this condition, because this is going to be, since it's a neonate, we can't supplement it with oral medications also, and the treatment has to be more vigorous. So prevention is better than cure. So we supplement the baby with, we start the baby once it's been diagnosed. It's mainly caused by Neisseria and chlamydia infections. So once it's diagnosed, we'll start with prophylactic third generation antibiotics, cephalosporins we start with. Next, coming to the lid infections. Second commonest to the bacterial conjunctivitis is the lid infection. So once in a lifetime, we have encountered this stye or chalazion. Once in a lifetime, starting from the childhood till the adulthood, or we would have seen in our neighbors also presenting to us, asking that what we can do for the condition, and they'll be very much worried. Whatever the eye infections or the disorders of the eye, the patients are much more worried, and that too in the children, the parents will be more worried. So we would have seen that. So there is some slight differences between the stye and the chalazion. So stye is often an acute presentation. Stye is often an acute presentation, that it is going to present you with a diffuse swelling over the lids. Diffuse swelling, erythema is going to be there, and the lid swelling is going to be there. And if you closely note that stye is going to be closer to the lid margin and the lashes, whereas chalazion is away from the lid margin, and it is a chronic, painless swelling. It is a chronic, painless, localized swelling, whereas this is going to be diffuse, tender, erythematous swelling that is closer to the lash lines. So these are the major clenching features. Why we have to differentiate between this? Because stye is an acute condition. If you're not treating up stye is mainly of conservative management. We can give warm compress, and we have to mainly give warm compress. If the warm compress is being properly given, we do not need the antibiotics, topical antibiotics we do not need. If the stye is not being treated adequately by giving warm compresses, it will progress on to the chalazion, which is again a chronic painless swelling, or the chalazion can present per se. So also, if a child gives you a recurrent history of chalazion, that means the child is having some huge uncorrected refractory disorder. It can be huge or it can be mild. So we have to look into it. We should not just treat the chalazion or the stye. We should look the underlying cause also. The most common cause will be the uncorrected refractions. So chalazion, actually, it is a chronic presentation. So whatever warm compress we give, it is going to persist often. We can add topical steroid and antibiotic drops. Still, if it's not resolving and it is increasing in size, we have to go for incision and drainage. I here want to discuss that how to give lid warm compress and how to prepare a lid scrub, because that is very, very vital as being an ophthalmologist, or this should be known to parent. It should be properly counseled to the parent. So let's go into the video.
There are several ways of cleaning your eyelids.
See. So there are 3 ways to clean our eyes. One is giving the warm compress, another is the lid scrub. Warm compress, I told you, we can give it for the lid infections. Also, in case of the viral conjunctivitis, we give cold compress. So warm compress and homemade lid scrub. So warm compress in case of stye and chalazion. If the warm compress is being properly given, it will resolve on its own. There is no need of antibiotics. So that is the importance of the warm compress. So here I'll just swipe through.
Warm compresses.
So before anything, we have to wash thoroughly our hands.
Wash your hands thoroughly.
Then we have to place a hard-boiled egg or a hard-boiled potato in a towel, and then we have to roll it like this. Okay. Then we have to place it in the back of the hand, and we have to measure how much is the warmth. And then we can directly place into our eyes, and we have to keep it for like 15 minutes. The mechanism of this, how is it going to relieve my stye or chalazion, if you ask? This is going to loosen the crust that's already there sticking to the lids. And then it's also going to free out the secretions of the blocked oil gland or the meibomian gland. Chalazion is the infection of the oil glands. So the oil gland secretion which is blocked, it's going to get relieved by the warm compresses. So with this, we can relieve the episodes of sty and chalazion. The second thing is how to prepare a lid scrub.
The warm compress will...
So how to prepare a lid scrub? Before everything, we have to wash thoroughly our hands. Then this is 1 cup of lukewarm water. To this, we have to add a drop of Johnson & Johnson baby shampoo. And then we have to stir it well. Then we have to dip a cotton bud into it. Then we have to take it. As shown in this video, we have to clean from inner to outer. It should never be reversed. We have to start from the fornix, go to the lid margin, then to the lashes. Same thing in the upper lashes also. From the fornix, lid margin, then the lashes. So this is how we have to clean our lashes. Be it in conjunctivitis or be it in any lid lash infections like blepharitis, we have to clean in such a way. Okay. Next infection is that preseptal cellulitis. This is very important because this per se is not an emergency condition. It has good prognosis, preseptal cellulitis. But why we have to look into it is that there is one more condition which is going to mimic the preseptal cellulitis. So this is the superficial infection of the soft tissue infections of the eye in front of the orbital septum. So basically in both of the conditions, be it in preseptal cellulitis or in the orbital cellulitis, the child is going to present you with diffuse swelling of both of the lids. There will be huge swelling. There will be huge edema on both of the lids. There is going to be redness and tenderness. Okay. Both of the vision threatening condition, that is the orbital cellulitis and preseptal, both are going to look similar only. But what we can do, we can actually differentiate with basic examination. So when to suspect, why is it happening like this? This happens secondary to the insect bite, like in the bee sting, spider bites, or any local skin aberrations, or sometimes it can be extension of the lid infections, like in the sty and chalazion, they can also extend and they can present as preseptal cellulitis. Other important history is that there can be concurrent present of the sinusitis. So the extension of infection from sinus can also present similarly. Okay. So, okay, these are the main differences. So if you see the lid swelling and erythema, tenderness, it's going to be there in both the preseptal and orbital cellulitis. So with that, we don't often differentiate. But if you look into the pain, there is going to be more of deeper eye pain. There is going to be more of a deeper eye pain, and the tenderness is going to be more. And if you check for the extraocular movements, if you ask the patient to look up on the sides, there's going to be more pain with the extraocular movements in case of the orbital cellulitis, and there is going to be enlargement or protrusion of eyeball from the cavity. Why the protrusion is happening? Because something in the orbit is pushing the content and it is causing the proptosis. So there's going to be proptosis. Whereas in preseptal, it is more superficial. So in superficial infection, there will be inward movement of the eyes. We can't see the eyeball outside. So in proptosis, there's going to be enlargement and pushing of the eyeball outwards. Since the eyeball is pushed outwards, the child is having proptosis, there's going to be double vision in the orbital cellulitis. And orbital cellulitis is a condition in the orbit. As I said, mentioned earlier, orbit infection of orbit is orbital cellulitis. So something in the orbit is compressing the optic nerve also. So the vision will be grossly diminished in the orbital cellulitis when compared to the preseptal cellulitis. Preseptal cellulitis child will reach 6.6 or 6.9. It won't be worse than that. Whereas in the orbital cellulitis, it will be a very progressive diminution of vision. And if you see orbital cellulitis is a systemic condition, it's not of a localized cause, they'll be having more of high-grade fevers. Next, coming to the viral infections of the lids, this is molluscum contagiosum. If you see, the lesion looks like this. This is called umbilicated lesions. Umbilicated lesions. This would occur all over the face, especially in children. This is the most common condition. Also, it can occur in the lid margins. And if you carefully note in this picture, this is closer to the lashes. and it is touching the cornea. So this can per se can erode the conjunctiva and cornea, can present like corneal ulcer or can present with conjunctivitis, and it can closely mimic. So that is why I told in my earlier slide, we have to always inspect the lid infection, which can be a secondary cause to the conjunctivitis. Next, if you see here, this is a manifestation of herpes simplex of eye. This is called herpes simplex dermatitis. If you very well see, there is a lot of small vesicles which has bursted out and it has caused crusting of the lashes. So this is the typical presentation of herpes simplex virus. The herpes simplex is very common in children. That too, the type 1 is very common in the children and it spreads to the other children also. So in case if we are seeing like this, we have to suspect for the herpes simplex infection. See, if you have seen, the vesicles have ruptured and it has caused some crustings. So there is some superficial abrasion in which the secondary bacterial infections would add on. So while treating this infection, we have to keep in mind that we have to treat for the viral infection with antivirals as well. We have to add an antibiotic cover to prevent the superadded infection. Next is the NLD obstruction. I told you in the first slide only, the lacrimal apparatus system. If you are not knowing, I'll show once. Yeah, this is the lacrimal drainage system. If you see, this is the puncta and this is the upper lower canaliculi. This is the lacrimal sac. So if there is any obstruction anywhere in the sac, usually there can be punctal obstruction or canalicular obstruction. There can be obstruction anywhere in the pathway. So anywhere in the pathway that would lead on to collection of secretion. It's not draining properly. So it is going to the secretions of the tear or whatsoever, it's going to accumulate here and it's not going to drain. So this can per se can lead to low grade infection. Okay. So this can per se lead to low grade infection. And this is 6% of the newborns are presenting with this. They will typically present to you with day 2 or day 3 of life. Since it's a congenital in nature, day 2 or day 3 of the life, they're present with watering, which is non-stopping. Associated with superadded, some redness can be there. And after a week, they can present with some intermittent discharge and often there would be crusting along the lid margin. And if you see, the main thing is the counseling. We have to counsel the parents about the importance of the massage of the lacrimal sac. We have to properly counsel the patient that how important is the role of massage of lacrimal sac, because if they properly do and they frequently do the massage of the lacrimal sac, it is going to prevent 90% of it. It's going to relieve the obstruction. Whereas if they only 10% of the patients will be requiring topical or IV antibiotics, if that is also not resolving, some 5 to 6% of the patient will be requiring primary surgery for the cause. So we have to insist upon how important is the conservative management for the NLD obstruction. So finally summarizing, eye infections, as we discussed these, you would realize how counseling would be important and how conservative management would save the vision or would save the progression of the eye infections. And you would properly, you will, by the time I think you'll be knowing like how important it is to advise the patients regarding the eye care and to prevent the further recurrence of infections. Thank you.
Thank you, ma'am. It was really an informative session. I hope the participants got a clear idea about how to care the eye. I would like to call our next guest speaker, Dr. Vanaja Vaidyanathan, Director and Consultant Ophthalmic Surgeon, Jyoti Eye Care Center, to share a few words.
Warm greetings to all.
Yes, ma'am.
Outside, I would like to thank Vinayaga Mission College of Nursing, Vinayaga Mission's Research Foundation. Am I audible?
Excuse me, ma'am, just a second, ma'am.
Yeah.
It's just a small introduction about Dr. Vanaja Vaidyanathan, ma'am. Ma'am is the founder and medical director, consultant, and chief ophthalmic surgeon of Jyoti Eye Care Center, which is celebrating 23 years of eye care services since 1998. Ma'am is also a chairperson of for Indian Medical Association Women Doctors Wings Puducherry chapter and National IMA Standing Committee for Organ Donation member. And ma'am also completed fellow of All India Collegium of Ophthalmology in 2012, conferred honorary by All India Ophthalmological Society, only one candidate at national level. Ma'am presented with more than 100 papers, posters, videos, chaired sessions in state and national conferences, and served as a member of editorial board, TNOA journal, more than for 5 years. And ma'am also won best paper award for 4 times in TNOA. And JECC has cared for more than 7 lakh eye patients, of which 3.5 lakhs are totally free, and conducted more than 1,300 eye camps and eye donation awareness program through Jyoti Eye Care Foundation. And also she has done more than 50,000 sight restoring surgeries and more than 30,000 sight saving laser procedures. And ma'am is the first person to start the most advanced corneal lamellar procedure in Puducherry, by which one donor can help 4 people to see. And ma'am is the first person to start state of the art dry eye clinic with LipiScan and LipiFlow in Puducherry. And she is an active Rotarian, as president had done more than 500 projects with a record unbroken till now, and past and first women assistant governor, and was chosen the best AG first women district strategic committee chair, public image. And she has won more than 100 awards for community works, like a few of which are Women Empowerment Award by National IMA DW, and International Women Achievers Award by Legal Rights Council, and Women Ophthalmologist of the Year, and Lifetime Achievement Award by IMA Puducherry, and the Outstanding Women Entrepreneurship Award in 2019 by IWN and BNI, and Achiever Award by Rising Star by Times of India, and Best Medico Award, Outstanding Young Person and Young Indian. And ma'am also got a Puducherry Shakti Award and Service Excellence Awards by both Rotary and Lions Club. And her special interests lie in the field of women empowerment, holistic health, yoga, meditation, and spirituality. The main mantra of Jyoti Eye Care is love, peace, and happiness has become the main mantra of Jyoti Eye Care in the life of Dr. Vanaja Vaidyanathan ma'am also. So, ma'am, now you can proceed, ma'am.
Thank you,
Sorry,
Dr.
ma'am.
Sudha. Is it Dr. Sudha who introduced? Am I audible?
Yes, ma'am.
Yeah. Is it Dr. Sudha who introduced me?
No, ma'am. Myself, MSc second year student, ma'am.
What is your name?
Sayalvidi, ma'am.
Kayalvidi. Thank you so much, Kayalvidi, for that wonderful introduction.
Thank you, ma'am.
I would like to thank Vinayaka Missions College of Nursing, Vinayaka Missions Research Foundation, and Department of Child Health Nursing for this wonderful seminar on disorders of the eye in children, and also for inviting me to this seminar. I give my greetings to Dr. Sudha and Professor Dr. Sudha, who is the Professor HOD Department of CHN, and also I would like to give my greetings to Dr. Muttamirchelvi, Principal of VMOCN. Also my special greetings and wishes to all the faculty members, including Mr. Prabhu, Assistant Governor, Department of CHN, and my special thanks again to Ms. Kayalvidi. And also I give my greetings to all the co-speakers. I had the opportunity to listen to Ms. Valarmati and also Dr. Kirtana, both of whom gave very extensive and elaborate presentation, very comprehensible presentation. Unfortunately, Mr. Sandeep's presentation I missed, but I'm sure they all did wonderful presentations. Without much ado, I will go on to my topic. This is not actually the clear-cut nursing topic, because it is something more social. Now the digital eye strain and eye problem has become a social issue. With this COVID-19 pandemic and lockdown, all of us are in front of computers, mobile phones, and laptops. We are spending a lot of time in front of the screen, and it is important that we have a comprehensive idea about digital eye problems. And 1 minute, I will just share my screen. Is my PowerPoint visible?
Yes, ma'am. It's visible, ma'am.
Yeah. So today I'll be talking on digital eye problems, eye care in children. I think almost the bulk of the care needed have been discussed by both Ms. Valarmati and Dr. Kirtana as far as refractive errors and infections are concerned. I will cover up some of the other eye care points that need to be discussed, and of course, eye donation, which is a very important need of the hour. So anatomy of the eye, I'm not going to go into details. It's only to say that eye is a 1 inch organ, and it has been given so much importance because we all know that eyes are the most important sense organs. Eyes are windows which help us to see the world, mirrors of our magical mind, most importantly, the light of our lovely life. So we'll have to take good care of our eyes in order to retain this light of life throughout our life. So when we look at eye itself, I'm not going to talk about all the structures mentioned here, but there are 3 very important structures which are important, which are very relevant for discussion today. The front transparent window, the cornea, which is the VIP of the eye, very important part of the eye. Then we have the lens. We have the iris in between with the pupil. Light passes, light gets refracted via this cornea, then anterior chamber, then you have the pupil. And the lens is the next very important structure. Already a lot of importance had been given and discussed about it. And the VVIP of the eye, very, very important part of the eye is the retina. So if cornea is the VIP, retina is the VVIP, because even if cornea gets damaged, we have a corneal blindness, we can replace the cornea with corneal transplantation. Whereas if the retina gets damaged beyond a certain level, irreversible level, there's no retinal transplant till date available. A lot of trials and research is going on, but we cannot transplant retina and the person goes irreversibly blind, just like in diabetic retinopathy, and also same way in optic nerve. If there's some damage happening, it's going to make the person irreversibly blind, like in glaucoma. So these 3 structures we all need to know. And as you all know, physiology, the functioning of the eye is similar to that of a camera. Like the window of the camera, it's not the digital camera of today's times. Today we all have camera in the cell phone. So that's not the camera I'm talking about. The olden days camera where we used to have a window, and then we used to have a lens inside and a film which captures the images and which has to be washed to get the photo. So likewise, we can compare the functioning of the eye to that of a camera, but even the most sophisticated camera cannot equal the wonderful functioning of the eye. That's what I wanted to mention, because many of these things have been covered in the refractive errors. I will just skip that. And the human eye, the eyeball, cornea, all these, the parts are very, very important, because see, when you look straight, you will only see the dark portion of the eye. The cornea is totally invisible when you see the eye of a person. Only when there is an abrasion or a disease on the cornea do we see that extra layer on the iris. So the dark portion of the eye is the iris, over which you have a transparent dome, like the headlight dome, the cornea, and this cornea is totally transparent when it is normal, and it gets visible only when it is diseased or injured. So the corneal aberration or the corneal foreign body or corneal opacities only make the cornea visible. So this one point I just wanted to highlight for all of you to know. Why are we giving so much importance to this just 1 inch ball? Because we know that there are lot of blind people in the world, 45 million blind people in the world, and 1/3 of them are in India, 15 million in India. And this is not all, the number is, it is increasing every day. This assessment was done in 1999, and they said the number is going to be doubled by the year 2020. And the visual impairment number, the vision very less than say 660 or 3/60, that number is 135 million. And it was predicted by World Health Organization, this number also is going to double in 20 years time. And that's what has happened. Now we have more than 250 million visually impaired people. Prevention of avoidable blindness has become the goal of World Health Organization, International Agency for Prevention of Blindness, national, our own national government and non-governmental organizations, philanthropic institutions, all of them have joined together to form Vision 2020, the right to sight. It was created in 1999, and the assessment by Vision 2020 says that the commonest causes of blindness in adults are cataract. The second place has been given to childhood blindness, because when a child goes blind, the number of blind years are much more than when an adult. The number of blind years are much more, and the mental agony also is much more. And the economical burden to both family and to the nation is also again much more. So importance has been given to childhood blindness, and second place has been given for when we look at the common causes of blindness. I will go into the causes of childhood blindness subsequently, but looking at the other causes of blindness in adults, glaucoma, diabetic retinopathy, infections of the eye like trachoma. Dr. Kirtana was mentioning a lot about the infections in the eye, the follicles and papillae. Just one point I would like to highlight here. The papillae are commonly seen in bacterial infection, and the giant papillae are seen in allergy. So that one point I wanted to highlight. Giant papillae causing shield ulcer. The follicles are present mainly in viral infection, chlamydial infections, and toxic drug usage, chronic drug usage, like usage of glaucoma drops for a very long time, or misuse of drugs by drops by patients for a long time. That will lead to follicular reaction. And follicles are generally seen in the lower eyelid, and papillae are generally noted in the upper eyelid. These are some differentiating points for papillae and follicles. So that's very, very important. And chlamydial infections by trachoma, that's common in the North India, not so common in South, but that is one of the causes of blindness in both children and adults. When coming to causes of blindness in children, it is very sad to note that vitamin A deficiency is the leading cause of blindness in developing countries like ours, like in India and other Asian countries. Vitamin A deficiency is still the leading cause of blindness in children, especially in North India. South India is much more developed, and we have the midday meals, the free midday meals in schools, with providing eggs and milk and all that. So vitamin A deficiency causing blindness is not so common in South India, whereas in North India, it is quite common to see this problem. And refractive errors already dealt in detail, and congenital abnormalities like congenital cataract, glaucoma, congenital glaucoma or buphthalmos, we call it. Big eyes are beautiful, but then when they go on to becoming like this, causing corneal opacity and big buphthalmic eyes, they are really scary and sight threatening to the child. And now, thanks to pediatricians, more and more babies, very tiny babies, less than 1 kg babies are also being saved. And retinopathy of prematurity has become one of the leading causes of blindness, because this importance all of you should know as nursing staff members, not only nursing staff, all doctors, all pediatricians, all common people should know, because lot of premature babies go blind due to not getting screened the babies before the age of 1 month. At 20 days of birth, the first screening should be done in a premature baby. This point is very, very essential. If it gets missed out before 1 month of age, the premature babies who have the problem, who have the retinopathy of prematurity, are going to go permanently blind by the 2nd or 3rd month itself. And you go and do the screening in the 2nd or 3rd month in an affected child, it's not going to help. By then, there is going to be vitreous hemorrhage, vascular proliferations happening, scarring, causing tractional retinal detachment by the time the child presents to you in the 3rd month or later. So please remember, all premature babies should be screened before the age of 1 month, definitely. Please remember this. Please advise the parents. Please remind all parents of the premature babies to have the dilated examination of the fundus before the age of 1 month. So screening for eye problems starts not only when the child has a problem. It has to start at birth. In fact, problems should be picked up. Anomaly scanning is done when the baby is in utero itself. Anomaly scanning picks up any problem in the neurological system or eyes, very gross congenital defects when the baby is in utero. So screening, anomaly screening is one of the screening for eye problems. Then we have the at birth. I told you about the premature babies need to be screened before the 1st month of age. And then on any congenital which are grossly, if there's any gross abnormality seen externally, it has to be addressed to congenital, any white reflex in the eye, any congenital problems like congenital cataract, the corneal opacities, congenital glaucoma, corneal lesions, corneal opacities, corneal ulcers. All these can be externally seen when babies have a problem and need to be addressed immediately, even before the age of 1 year. But the routine screening for sight starts at school going age, if not preschool age. So when the child starts going to school, preschool or school, it is important that sight has to be checked. It's very difficult to screen preschool children for sight, but definitely with the various children screening charts available these days, the picture charts and the other Landers charts, there are several children chart available with which children can be screened for sight at preschool age. School going age is again every year children need to be screened. That's why at Jyoti Eye Care Center, through our Jyoti Eye Care Foundation, we do school screening program as a part of community outreach to all schools at least once a year or once in 2 years to pick up problems at an early stage. So vitamin A deficiencies can be picked up during screening. Like, for example, we can see this white hot spot, which is a dry silvery structure, still silvery abnormality in the conjunctival portion. This leads on to corneal drying, corneal cirrhosis in vitamin A deficiency, corneal melting or keratomalacia in vitamin A deficiency, leading to corneal blindness. So it's very important that we pick up vitamin A deficiency at an early stage. Then school screening is important to pick up refractive errors, congenital defects, squint and amblyopia or lazy eye status. Any childhood eye problem, if not picked up before the age of say 8 to 10 years, it's going to lead to irreversible visual impairment or blindness called amblyopia, because even if you go and correct the refractive error or the congenital defect after 10 years, the eye-brain coordination is not going to develop and it's going to cause amblyopia. So infections of the eye already dealt with by Dr. Kirtana. Very nicely she dealt with every infection. Only she said internal infection she's not going into, because that's something to be done by the treatment has to be done by the ophthalmologist. Endophthalmitis is one important problem post-operatively, both in children as well as adults. If you see some extra redness and extra anterior chamber reaction, if you start looking through slit lamp, you see anterior chamber reaction, a small streak of hypopyon. It is indicative of some infection in the eye, which if it is a streak of hypopyon can easily get missed out, and if you leave it alone, it's going to lead to vision threatening endophthalmitis later and sight loss which is going to be permanent. So very, very important to pick up eye infections at an early stage in children, because they cannot talk to you regarding their problems. They cannot cooperate for sight also, vision checking also. So it's very, very important in a post-operative case of a child. If you see a streak of hypopyon, it's an indication of endophthalmitis, and if you pick up that and alert to doctors, ophthalmologists, it's going to save sight of the child. We can give immediately take up the child for intravitreal injections and AC wash, culture sensitivity, and treat the infection of the sorry, can you please mute others?
Sorry for the interruption, ma'am.
Host or co-host can kindly mute others.
Yes, ma'am, I have done it, ma'am. Sorry for the interruption, ma'am.
No problem. So the presbyopic age old age screening has been done for other causes of blindness, which I already mentioned. I will skip that because it's mainly for the childhood eye problem, that childhood eye care that we are talking today. So quantitative, as I mentioned, the vision, quantitative vision blindness and visual impairment are all going to affect the vision and cause blindness. But today I'm going to talk about one, this I will skip. This is a cataract surgery, which I thought just to show that we are doing cataract surgery through a needle nowadays, micro incision cataract surgery, both for children and adults. It has become micro incision surgery through a needle. And see phaco emulsification, micro phaco with Centurion machine. This is IOP based fluidics. The cataract surgery is done through a very small incision. It's just a half a minute clipping. I just go very fast. When a hard cataract can be operated through a small incision these days. For a child, it has to be done under GA, whereas in adults, it is done under topical anesthesia. The pieces are emulsified, chopped into small pieces and emulsified, and intraocular lens is injected into the eye through a small incision itself. It's foldable lens which is injected into the eye. Nowadays for children also, earlier doctor, I think Miss Valarmadi was talking about aphakia. Now we are implanting more and more intraocular lenses in congenital cataracts. We are not leaving them aphakic. We are starting implantation even slightly before 2 years of age. Only before 2 years, aphakic corrections would be needed, aphakia, and then secondary IOL implantation can be done at a later stage for children with congenital cataract. So this glaucoma part I will skip because we are going to talk about qualitative vision or the dry eye problem. So digital eye problems, when we talk about dry eye, is the most important condition which needs to be addressed to. So tears keep the surface of the eyes wet, lubricated, protected, comfortable, and they help to maintain clear vision. If eyes do not produce enough tears, or if the tears dry too quickly, the condition is termed as dry eye. So dry eye can be temporary or a chronic condition. What are the causes of dry eye? So there are 3 layers in the tear film. All of you should know about the structure of the tear film in order to understand dry eye. So there are lacrimal gland which are present in the supratemporal part. Already Dr. Kirtana was talking about the lacrimal gland, the lacrimal drainage system. So these lacrimal glands secrete the aqueous portion or the watery portion of the tear film, the bulk of the tear film. The innermost mucus layer is secreted from the goblet cells present in the surface of the eye. So they make the water adhere to the eye surface. Otherwise, water cannot stand on the eye surface. So the mucus layer which comes from the goblet cells on the eye surface help the watery layer to stand on the eye. And there is the meibomian gland. Meibomian gland, already you heard about the meibomian gland getting obstructed, causing chalazion. So these meibomian glands or the oil glands, they are very useful to produce oil layer of the tear film. So whenever you blink, there is a spurt of oil coming out of these meibomian glands, and it covers the watery layer with a thin film of oil. So this oil keeps the watery layer on the eye surface. So for the tear film to stabilize on the eye, you need this oil layer, and the oil layer can form only if you blink and allow the meibomian gland to secrete the oil into the eye. So if you are not going to blink enough, there's not going to be enough oil inside your eye. So this is what is happening now. We are all before gadgets. We are all before computer and mobile phones. We are not blinking enough. So what happens? Instead of blinking 20 times a minute, we are blinking hardly 5 to 7 times a minute. And this causes less of oil coming into the eye, and the water cannot stabilize over the eye in this tear film, and it gets easily evaporated or it keeps spilling out. Some people, there will be watering due to spillage from the eye due to deficient lipid layer. In some people, it is due to excessive evaporation and drying of the surface, causing reflex tearing, reflex watering or reflex tearing from the lacrimal gland. So the excess, some people have watery eyes because of either the lipid layer being deficient and the water not being able to stabilize over the eye, or due to reflex tearing, excess secretion from the lacrimal gland due to deficient lipid layer again. So very, very important that you remember that blinking is important. There are 340 million people worldwide, 10 million added on every year, and every third Indian has dry eye, they say. Especially people who are on computers, 37% of them seem to be having this problem, and 23 people who are 23% of people who are driving, 19% who are watching television and screens for a long time, and 16% who are driving out in the night, and 5% who are on the airplanes. So these are the people who are going. This video I will skip. It is present in the YouTube. Please go and subscribe to my YouTube channel. I'm giving a lot of eye educative videos every day. So you can subscribe to my YouTube channel. If you just type out Dr. Vanaja Vaidyanathan, you will see a lot of YouTube channels, and also my Facebook and our website www.jyotieyecare.com. This video is a comprehensive overview of dry burning or scratchy sensation in your eyes. Do you have blurred vision or eye fatigue or find it? This I will skip because it is going on to go for 5 minutes, and I think it is already very late. I'm standing between you and lunch. So I will skip that. And 80% of all dry eyes, meibomian gland dysfunction, MGD we call it. This is due to lack of blinking. The meibomian glands get blocked, get stagnated because we are not blinking. The oil gets stagnated in the meibomian glands, and they go on to get thick. They become thick material. When they cause block, it is going to cause the chalazion. If they get infected, it's going to cause aureolum internum. And when they last for a long time, they're going to go into dropout like this. So we have in our hospital the lippy scan, which shows the amount of damage in the meibomian glands. See, this is about 25% damage. We have 30 to 50 meibomian glands each lid, upper and lower lid. And when these glands get damaged or go into dropout, it's going to these are permanent dropout. This is permanent damage, and we see very young people coming with such gross damage, 90% damage, etc. So it's very, very important that that we remind people on computers and mobile phones to reduce their screen time, and also to blink enough in order to avoid this MGD. 80% of all dry eyes are due to meibomian gland dysfunction. So evaporative dry eye due to the less oil, can be worsened by AC, dry, dusty atmosphere, infrequent blinking, or computer vision syndrome, we call this CVS, long-term use of contact lenses, post-refractive surgery. In LASIK surgery, 360 degrees cut is given and corneal nerves are cut. So the reflex tearing gets reduced because the nerves take few weeks to regenerate, 6 weeks to 3 months to regenerate, and patients will have a lot of dry eye problem during this time. So till the corneal nerves regenerate. So post-refractive in LASIK surgeries, it is going to happen, and also post-cataract surgery due to usage of drops, excessive eye drops with preservatives, which cause surface damage. This can happen, dry eyes can happen. How to diagnose dry eye? So slit lamp examination under high magnification using fluorescence staining. Many of the dry eye problems can be picked up with fluorescent staining and also with the tear breakup time, T-BUT we call it. The Shermer's test is done using a tear strip. This measures the amount of fluid content of the watery content of the tear film. I told you the three parts of the tear film. The watery content is measured using the Shermer's test. Shermer's test 1 is done without anesthesia, and the Shermer's test 2 is done with anesthesia with the topical anesthetic drops. So when Shermer's secretion is very low, it means the lacrimal gland is affected, lacrimal inflammation has occurred. Even in evaporative dry eye or MGD, in the late stages, because of the surface inflammation, the lacrimal gland gets inflamed and goes into hyposecretion. It's the fourth stage, I would say, following meibomian gland, MGD, meibomian gland dysfunction. So tear breakup time is indicative of the amount of lipid secretion, lipid level in the eye. So if tear breakup time is less than say 10 to 12 seconds, it means the tear breaks up very fast, which means the lipid layer is very less, and less than 10 seconds is indicative of MGD. And we'll have to go in and see the meibomian glands for meibominitis or the grading of meibomianitis or meibomian inflammation. And also we'll have to go in and scan the meibomian glands with lipi scan and lipi scan, and the treatment for meibomian gland dysfunction when there is a lot of dropout, more than 25 to 30% dropout. Lipi flow is a treatment which is it's a warm compress vector pulsation, thermal vector pulsation we say. It gives warm compress to the lid margins, and it milks out the contents in the meibomian glands. That's called lipi flow. So lipi scan or the meibography, which is the study of the meibomian glands, and lipi flow is the treatment for meibomian gland dysfunction. For the dry eye, the commonest cause of dry eye, which is the meibomian gland dysfunction. So coming to eye care in children now, a lot of children are before computer. Earlier, it used to be only computer professionals and adults. Now, children are in front of computers and mobile phones for their online classes. Due to COVID-19, all schools are closed and online classes are going on for children. And it's very, very important to know about computer vision syndrome. Symptoms of computer vision syndrome are eye strain, headache, blurred vision, slowing of focus of eyes, blurring in the distance after near work, and eye irritation, and neck and shoulder pain, backache, etc. because we are sitting stiff before the computer in bad postures. So it's how to correct the digital strain, how to correct this computer vision syndrome. It's important to remind the children to blink frequently, to lubricate the eyes, and also to prevent dryness, and conscious effort should be made to blink more frequently. And something called 20-20-20 rule. Every 20 minutes you take a 20-second break, blink, look at 20 feet away, so that your focusing muscles, the accommodative muscles which go into spasm, get relieved, and they reduce the eye pain, headache. This 20-20-20 rule is to reduce eye pain, headache, and all the symptoms associated with computer vision syndrome. And then use anti-glare coated spectacles, which will also protect from radiation hazard, and also it will have a mechanical protection to drying of the tear film. The evaporative dry eye can be prevented. Also, The position of monitor is important, 20 inches at least from the eyes and also just below eye level. And lighting and surrounding background lighting are all important when the children are sitting before computer or using mobile. They have to maintain good distance from the eye. So if for children, it is very important that their legs should not be hanging, the 90-90-90 rule. So the body should be at 90 degrees to the thighs and at 90 degrees to the legs again. If their legs are hanging in the air, a small stool or a small step can be given for the children so that the legs rest on the footstool. Very, very important. So monitor location, anti-glare coating of the both computer screen as well as protective goggles. Earlier in children, we used to say glasses should be plain white, but nowadays we advise even for children anti-glare coated glass because they are all now using computers and mobiles, and also the 20-20-20 rule, etc. So blinking also should be encouraged. So vitamin A rich food should be advised. Also the omega-3 fatty acid rich food, fish and walnuts are rich sources of rich sources of omega-3 fatty acids, which are essential for the oil glands. Also flax seeds, chia seeds, which are not usually seen on our food. Vegetarian source of omega-3 is very less, only soya bean, soya milk, and walnuts. So walnuts can be advised for children having a dry eye problem, because the oil glands can be made free-flowing if they use omega-3 supplements and also omega-3 rich food, and if they avoid oily food and deep fry items, which can cause clogging of the oil glands. So always use protective glasses for computers and when going out on two-wheelers. Even children are accompanying parents, it's important to protect eyes, and also in sunlight and while watching welding, etc. Excuse me. The infections of the eye have been very extensively covered by Dr. Kirtana, but one very important sight-threatening infection, the corneal infection, which can be easily picked up by the nursing staff, anybody, white reflex on the cornea. It has to alert it, or even a white dot on the cornea should alert the staff members, and they should refer to the ophthalmologist immediately. Red eye should not be always thought of as conjunctivitis, and the corneal infiltrate should not be missed out. Corneal infiltrate or corneal ulcer, corneal infection should not be missed out. Very, very important. So cleanliness is next to godliness. Lid hygiene, scalp hygiene, and personal hygiene are very, very important. Eyes, nose, and mouth are portal of entry for diseases. We always teach the paramedical staff in our hospital not to touch eyes, nose, and mouth, even before this COVID season. Now for the COVID, it has become very mandatory that people should not meddle with their eyes, nose, or mouth because they catch the infection. Even otherwise, even before the COVID infection, it is important that we do not meddle with our eyes with dirty hands, because we are going to catch viral infections or other infections easily. So never watch TV in dark room or very close. Reading in dim light in bad postures should be avoided, or while traveling should be avoided. Light should fall on the book, and good distance should be maintained. And sitting straight and maintaining good distance while reading is very important. And in case of fall of foreign body, fumes, fireworks, or chemicals, already about chemical injuries also it was mentioned. So immediately the first aid would be to wash with clean drinking water or with saline or ringer lactate, or immediately refer. Dr. Keetana was mentioning about ring lactate infusion. It's washing eye to wash out the chemical and till the pH reaches a normal. That's what she was mentioning. So it's very, very important to wash out eyes and thoroughly, and also we'll have to evert the eyelids and double evert eyelids to see up to the fornices for any chemical crust, especially the alkalis, the lime particles, sunambu they say. Sunambu particles will be seated in the deep fornix, and if you do not wash out the sunambu after several days and weeks, also damage will keep on happening, and it's going to cause symblepharon and severe ocular surface damage and ocular surface disease in the long run. So very, very important. So last portion, just few minutes I will take, 2-3 minutes I will take. Eye donation, corneal blindness, 3 million corneally blind adults and 1 million children waiting. And we get hardly say highest had been only 63,000 corneas received in the year 16-17, and highest corneal transplants in a year 44,000 only. The corneal utility rate is only about 50% on an average because of several factors which do not allow you 100% utility of the corneas. So though 8 to 9 million deaths are happening every year in India and only 3 million waiting, we have hardly 65,000 highest that has been received. This number, they're trying to raise it to 1 lakh at least in a year, but it is not happening. So corneal blindness is treated with corneal replacement or corneal transplantation. It's called penetrating keratoplasty. And the newer procedures, I want you all to know about the most important advancement in the corneal transplant, the lamellar procedures. The message for today is one cornea can be divided into two, the superficial part and the deep part, and can be used for two different people, deep anterior lamellar keratoplasty, and the top part can be used for DALK in case of keratoconus or superficial scarring, etc., corneal dystrophies, superficial corneal dystrophies, etc., stromal dystrophies and all. Whereas the deep part can be used up in endothelial dystrophies. So one cornea can be used for two different patients to restore sight. So one eye donor can help up to 4 people in some cases. So usually one donor means sight to 2 people, but in special situations, we can give sight to up to 4 people. That's a new message. So one cornea getting split and used for 2 different people. So I will skip. This is a video, award-winning video, which shows that DSCK, how it restored sight to an old man. And also about DMAC, a new procedure that we presented and won an award. So eye donation nowadays, we are not removing whole eyes. Many places they still remove whole eyes, but we are taking only the corneoscleral button and we are putting it into the MK medium. Instead of bringing the whole eye and then doing it in the lamellar flow hood, we are doing it in the, we are removing the corneoscleral button and replacing it with a shell. So there is absolutely no disfigurement to the eye or the face after removal. It takes hardly 15 to 20 minutes for removing, and there's no delay in funeral arrangements. Eye should be removed within 4 to 6 hours of death and should be preserved in MK medium or cornisol. MK medium preserves for up to 3 days, whereas cornisol preserves up to 2 weeks. And replacement of the cornea by shells like the transparent shells or prosthetic shells. Even if the eye opens up, it looks very natural. So our youngest corneal from Pillai Chavadi Blind School, we had brought this child who had one eye not developed, the other eye corneal opacity, and for the first time at 12 years of age, she had the corneal transplant. Till date, she's living a normal life, married, and she's living a normal life with this transplanted eye. And likewise, a 92-year-old retired Susila Bai teacher, who is an old, this is the oldest keratoplasty patient we did, and she lived up to 98 years, and recently a year or two ago she passed away. Till then she was living with this transplanted eye only, and living all alone, and she used to come for checkup and go all alone. So that's these are the life-changing and success stories of corneal transplantation. So one donor helps four people, up to four people see. Sometimes parts of the eye can be used for other purposes also. So that's why I've written can help four or more people see. Even the sclera can be used. Some parts of the cornea can be used for glaucoma implant surgeries, etc. So tectonic purpose and all that. So only a dead person can donate eyes. Only the cornea is transplanted, not whole eyes. Age is no bar to eye donation. Any person of any age can donate eyes. People with defective vision can also donate eyes. People wearing glasses, who have diabetic retinopathy, their retina would be very bad and they may be blind, but the cornea can be healthy and the cornea can be used up for corneal transplant or other purposes. Donated eyes should be taken and preserved within 4 to 6 hours. The eyes of the dead person should be kept close and the nearest eye bank informed. It takes just 15 minutes or less to remove eyes and there's no disfigurement. Donated eyes are never wasted. Even spoiled eyes are used for research and education. So please help us in this noble act. Call 1919. This is the universal toll-free number for eye bank. So our Jyoti Eye Bank is a recognized eye bank for more than 15 years now. We have state-of-the-art eye bank facilities, and these are some of the eye donation activities that we are doing in various places. Poster release, rallies. This year, because of the COVID-19 pandemic, we have to do only this sort of competition, virtual programs and competitions to create awareness. So please join us in our fight for sight. We have big waiting list everywhere. Even in our hospital, we have a register full of patients waiting for corneas. We don't get enough corneas, especially in this COVID-19 season. We are not able to take eyes at all because only in COVID negative patients from hospital cornea retrieval program, we can take corneas, and that is very less in number. And we are not having enough eyes, even for emergency purposes, whether it's in corneal ulcer perforation, impending perforations, etc. Patients are all put to wait because we are not getting enough eyes. So you can even virtually pledge to donate us, and especially the paramedical staff should become ambassadors of eye donation. It's not enough if you alone pledge to donate eyes. Nowadays we have family pledge forms. We are not asking individuals to pledge, we are asking families to pledge together. Only then it will work out, because if an individual pledges and if the family is not aware of it, it's not going to convert or happen. So it's important that families pledge. The whole family is aware, and they all of you will also have to create awareness among neighbors, friends, everywhere. So August 25th to 8th September is eye donation fortnight, and we do all these awareness activities during the time. Organ donation is yet another area where all of us have to play an important role to create awareness. In brain dead individuals, it is important that they can donate their organs, and dead people can also donate their whole body for anatomy, dissection, etc. And in JIPA and some of the medical colleges, body donations and organ donation platforms are available. Also online platforms are available in some of the websites. So now in COVID-19 season, all of you, please stay safe and stay healthy. Please stay at home, protect yourself and stop spreading the infection by the SMS, sanitizing, mask and social distancing. Never touch your mask, never pull down your mask to your neck. Neck is an exposed area, and when you pull down and then put it back, you're going to carry the virus which is present on the inner side straight into your nose. So please don't do that. It's very, very important not to pull down your mask. So thank you so much for your patient listening, and I'm ready to open and I'm ready to answer any of the questions or doubts that you have. Thank you. Thank you for the wonderful opportunity given to me by Vinayaka Missions College of Nursing and also by the Department of Child Health uh, uh, Nursing Department. Thank you.
Thank you, ma'am.
Yeah.
It was really an excellent session. I hope the participants will found this presentation informative and useful. And if the participant is having any doubts, means please put it in the chat box.
Can I view the chat?
Yes, ma'am. I request the participants to clarify your doubts in the chat box.
I think all of them are very hungry because it's already past 1:30. I think slight delay in sessions one after the other, and I think when I itself, I also I think a little sorry if I had taken a little more time because I had to cover all these topics. Thank you.
Thank you, ma'am. Now we are at the end of the session. I deem it a great honor to propose the vote of thanks. On behalf of Department of Child Nursing, I must mention our deep sense of appreciation and thankful for today's guest speakers who shared their precious knowledge with all of us. Thank you, ma'am and sirs. I also want to thank our principal ma'am and vice principal ma'am for taking efforts to make this session possible and contacting and promoting with other colleges and universities for participation. I would like to thank all the professors for encouraging students to participate. I would like to thank our beloved HOD Dr. Sudha ma'am and Professor Puducherry ma'am and my department for their moral support and guidance. And I extend a very heart thanks to the participants who blessed us with their presence and took out valuable time of your busy schedule. And last but not least, this event would not have been successful without the organizing secretary, Mr. Prabhu, Assistant Professor, Department of Child Health Nursing. Thank you so much, sir, for your efforts. It seems a great day. Thank you all for making this event successful with your contribution. Thank you for blessing with your presence. Now I would like to end the session officially. Thank you one and all again.